Welcome to Suffering to Sovereignty. This podcast explores how unresolved trauma shapes our nervous systems and, in turn, how we lead, communicate, and perform in high responsibility roles. Let me begin by setting a clear frame for this space. These conversations are not therapy. They are structured dialogues designed to increase awareness, restore executive function, and bring compassion to patterns that often go unseen in accomplished professionals. You are always in choice here. What you share, how deeply you engage, and when you pause. My intention is not to fix or diagnose. It is to help illuminate how nervous system conditioning influences behavior, decision making, and relational dynamics. If something in these conversations resonates with you, that does not mean something is wrong with you. It means your system adapted intelligently to your past experiences. Awareness is where sovereignty begins. I've been a physician a long time, and in that time, I have been in the next room or down the hall when a physician threw hot coffee in a nurse's face, when a physician kicked a trash can down the hall toward a staff member, when a physician started throwing charts at someone. This is what we in medicine call dysfunctional behavior. The AMA calls it disruptive physicians. Now, I'm not here today to talk to the disruptive or dysfunctional physicians. I'm here to talk to those of us who have to work with these people. I'm speaking to the nurse who hesitates before placing a page. I'm speaking to the resident who rehearses every word before calling. I'm speaking to the colleague who has spent years walking on eggshells. You shouldn't have to absorb someone else's behavior simply because that behavior may have originated in trauma. Understanding trauma does not require you to become that physician's therapist or to tolerate abuse or compromise care. Understanding it may, however, help you respond more effectively. The AMA calls it disruptive behavior and defines it by its effect. It includes speech or conduct that may negatively affect patient care or prevent members of the healthcare team from working together. This definition matters because A, this behavior isn't always loud, and B, none of this looks at the origins. So sometimes this is yelling, threatening, humiliating, or throwing things. Sometimes it's passive-aggressive, like refusing to answer a page, repeatedly becoming unavailable, delaying a response, or withholding information. This leads to avoiding particular colleagues or creating so much difficulty that you don't want to work together. And a big cause of this is trauma. So there are a number of things that lead to this kind of behavior, and let me just wing it here for a minute. A lot of this is trauma. Some of it is substance abuse. Some of it is depression. Some of it is anxiety. And all of that can exist together or on a spectrum. Yes, sometimes the person is just a jerk. But when you really get to know them, you learn that their jerky behavior is what kept them alive as a child. So again, trauma. Instead of deciding that someone is simply a jerk, we should be more careful by asking useful questions such as, is there a pattern that we're seeing? Trauma-related behavior is often organized around perceived threats. The trigger can be humiliation, loss of control, an accusation, an unexpected change in expectations, or process that the physician experiences as fundamentally unfair. Now, all of these things happen in medicine or in healthcare, but not all of us respond the same way. I've heard administrators say, oh, he has a fairness issue or she has fairness issues. And that phrase conceals more than it explains. What is often called fairness issues is actually hypervigilance. It may be a nervous system that has learned that rules change without warning and authority cannot be trusted, and humiliation is always one meeting or one word away. In some cases, that reflects PTSD, and in other cases, it's small t trauma. And administrators can't diagnose that, neither can a coworker. We can, however, recognize that an intense response to perceived injustice is not automatically evidence of bad character. It's also not automatically evidence of substance abuse. A fight response may look like anger, argumentation, intimidation, or an intense attempt to control the situation. A flight response may look like not answering the page, avoiding the unit, refusing to attend a meeting, or simply becoming unavailable. A freeze response may look like silence, detachment, confusion, or an inability to respond coherently. And a shame response may look like denial, defensiveness, blaming, or an inability to acknowledge an error. All of these things happen to all of us who are in healthcare for any length of time. But their frequency and the level of intensity are what make it dysfunctional. So how then do we distinguish a trauma response from someone who is simply using power badly? We can't do it with certainty from a distance. We can look at the pattern, the circumstances, the physician's capacity for repair, but we have to stay curious. We can't just jump in until we have control of our own emotions. We can't be reactive. Those things won't help anyone. So ask whether the behavior is triggered by situations involving threat, humiliation, loss of control, or perceived unfairness, or whether the physician uses aggression whenever it offers an advantage. Two different things. Notice whether behavior emerges when the physician appears overwhelmed, or whether it's calculated and selectively directed toward people with less power. Are they being bullied, or are they the bully? Pay attention to hierarchy. Does the physician speak to executives the same way that they speak to nurses, residents, and medical assistants? Does the behavior disappear suddenly when someone powerful enters the room? The ability to control that behavior in front of authority while directing it toward people with less power suggests something different from an indiscriminate state of physiologic overwhelm, doesn't it? Then we need to look at what happens after the threat is passed. Can the physician reflect on what happened? Can they acknowledge the impact, express genuine remorse, and participate in repair? Or does the physician minimize, retaliate, rewrite the event, and blame everyone and anyone else? Most importantly, does their behavior change? Trauma may not explain reactivity. It doesn't guarantee insight. It doesn't prevent a traumatized person from becoming a bully. Trauma and entitlement can exist in the same individual. People are more complex than that. And the purpose of asking about trauma isn't to decide that one person is innocent and another is guilty. Although administration often uses it that way, as does middle management, is to choose an intervention that has some chance of working. So as a colleague, what can you do? Well, in the moment, address the behavior, not your theory about its cause. Use clear, brief language that protects the team and yourself. Things like, I need you to lower your voice, or the patient requires a response to this page. Or, we can disagree, but you may not speak to me that way. Or, I am ending this conversation until you can continue safely. Document observable facts. Record what was said and what was done, who was present, how long a response was delayed, and what effect the behavior had on care. Avoid labels like unstable, addicted, personality disorder, or fairness issues. Those are interpretations, not observations. Don't confront a visibly activated person with an amateur diagnosis. Even if you're a physician, if you're not a psychiatrist, this isn't your strong point. Telling someone that this is their PTSD talking is unlikely to create safety or insight. It may actually intensify the threat response. So later, when the situation is calm, a trusted colleague may be able to say something direct and humane. Something like, I want to talk to you about what happened. Your response seemed bigger than the immediate disagreement. I'm concerned about you. I'm also concerned about the effect on the team. I won't pretend to know what's causing it, but something is happening, and I'd like to help. This is neither blame nor absolution. It is a boundary combined with humanity. And in this way, it resembles how you debrief after a code. We also have to examine where these responses may have been learned. If physicians were humiliated, bullied, threatened, and deprived of basic psychological safety during training, we cannot treat the resulting behavior as though it developed in a vacuum. Medicine has always rewarded emotional suppression, hypervigilance, perfectionism, and obedience, while calling humiliation, teaching, and endurance resilience. When the injured trainee later becomes the attending who injures others, the individual bears responsibility for the harm. But the institution also has to bear responsibility for the culture that helped transmit it. Fortunately, in large institutions, we're starting to see some of that accountability. But smaller institutions can't afford the programs that drive that. So we should stop asking, what's wrong with this physician? And we should also ask, what happened during training? What happens in this workplace? Who benefits from the current culture? Why colleagues stopped speaking up? Why the organization waited until the behavior threatened someone's privileges, employment, or license? And why distressed physicians are so afraid that asking for help will be used against them. That fear cannot be dismissed as paranoia. Employer-selected coaches aren't necessarily perceived as confidential or independent. These programs are perceived as, they're going to tell my chief medical officer or my CEO everything that I say to them. And so the trust doesn't happen, and you don't get the results you want. Programs connected to licensing authorities can possess enormous power over a physician's ability to practice. I personally know physicians who have lost their licenses over false claims that they were dealing with substance abuse. That said, there are also organizations that are working hard to change physicians' confidential access to mental health care, the Lorna Breen Foundation being leader amongst those. Because referral to one of these programs shouldn't be seen as punishment or as a way to transform a workplace complaint into an unsupported diagnosis of any kind. If support is offered, the physician should have access to genuinely independent professionals chosen by the physician, not their employer, and not an agent hired to protect the employer. Options include appropriately credentialed, trauma-informed clinicians when clinical assessment or treatment is needed. Coaching and clinical treatment are not interchangeable, but they do work well together. And the physician needs to know who holds the information, what remains confidential, and what circumstances require disclosure. For those of us who work beside or have worked beside a disruptive or dysfunctional physician, compassion does not mean silence. It means protecting one another without dehumanizing the person whose behavior is causing harm. It means setting boundaries without humiliation. It means documenting behavior without inventing diagnoses. It means refusing to let trauma become an excuse and refusing to allow professionalism to become a weapon. We don't have to decide whether someone is wounded or wicked before we protect the patient and the team. We can stop the behavior first. Then we can ask, what's driving it? If the healthcare system helped create the injury, then the system must participate in the repair. If you'd like to know more about this, I have some resources that will be posted in the podcast page. If you just want to know how to deal with it and manage your own emotions during this time, I highly recommend that you go to the podcast page and download the 7-Minute Reset. Thank you. As we close, I want to thank my guests for their honesty and their courage in sharing this conversation. These conversations matter because what we do not name, we carry. And what we carry silently often shows up in our bodies, our relationships, and our leadership in ways we never intended. If today's episode stirred something in you, I invite you to pause before moving on with your day. Notice what your body registered. Notice what feels familiar without trying to fix or explain. Awareness is not the end of the work. It is the beginning of choice. If you would like support continuing this conversation, I have linked a free nervous system awareness guide in the show notes. This short resource will help you find your personal triggers, recognize your default stress responses, and begin shifting from unconscious reaction to conscious choice with clarity rather than judgment. If this episode resonated with you, please take a moment to like, subscribe, and share this podcast with someone who might need this conversation. It helps this work reach the people who are carrying more than they let on. And if you are listening and feel a quiet pull to share your own story, I want you to know you are welcome here. If lived or witnessed trauma has shaped how you lead, how you work, or how you show up in the world, and you feel called to have a grounded, intentional conversation, you'll find a link in the show notes to apply to be my guest. Thank you for being here. Thank you for doing this work. I'll see you next time.